Okay, picture this. A patient gets wheeled into the emergency room. They're sick, really sick, and the doctor suspects an infection is raging inside their heart. Right then, the clock starts ticking. Every single decision matters. So what's the first move? Well, that's exactly what we're going to break down. So this is the big question, isn't it? The diagnosis isn't a sure thing yet. You've got a patient in front of you, and you have to make a choice. Do you go in, all guns blazing, with powerful drugs right away? Or do you hold back, watch closely, and wait for the lab results to tell you exactly what you're dealing with? As we're about to see, the answer changes completely depending on what you think is attacking the heart. And there is actually a name for this exact situation. It's called empirical treatment. It sounds fancy, but all it means is you're making a highly educated guess. It's not random, it's a strategic move based on years of training and the signs you're seeing, all before the tests come back. It's like the opening move in a really high-stakes chess match against an invisible opponent. So let's jump into our first scenario, the most urgent one, a suspected case of infective endocarditis, or IE. You gotta think of this one like a 5-alarm fire. This is not the time for caution. The only goal is to hit it with overwhelming force, and you have to do it right now. Yeah, when it comes to IE, waiting is just not an option. The strategy is to throw a combination of powerful antibiotics at it and fast. And the reason for that is pretty cool. It's for what's called a synergistic effect. It's just a way of saying that the drugs, when they work together, are way more powerful than they would be on their own. It's that classic 1 + 1 = 3 situation. Now, take a look at this. This shows you just how complex that battle plan really is. We're not going to read out every single drug name, but just glance at the level of detail. There are different game plans for a patient's natural valve versus a prosthetic one, and a whole other arsenal for complicated cases. This is literally the playbook doctors are using in the heat of the moment. And get this, while this huge antibiotic assault is happening, all the detective work is going on at the very same time. An echocardiogram gives doctors eyes on the heart, they draw blood cultures hoping to catch the exact bacteria red-handed, and they might even use something like a PET CT scan if the picture still isn't clear. It's a total two-pronged approach, attack and identify, all at once. Okay, so this all-in strategy seems like a no-brainer, right? But here's the twist. What happens if the patient doesn't have infective endocarditis? What if that aggressive approach, the very thing that could save one person's life, is completely the wrong move for another patient who looks almost exactly the same? And this brings us to our second scenario. This is where we flip the script completely. We're entering a totally different zone of medical thinking now. For conditions like myocarditis and pericarditis, which is basically inflammation of the heart muscle or the sac around it, the whole philosophy changes from attack to wait and support. And honestly, this slide right here, it boils the entire dilemma down perfectly. Infective endocarditis, that's usually caused by bacteria, so you hammer it with antibiotics. But myocarditis and pericarditis, they're most often caused by a virus. And throwing antibiotics at a virus, well, it's not just useless, it can actually be harmful. So the treatment has to be fundamentally different. So here's the bottom line. How many of those empirical, educated guess antibiotics are recommended for someone with suspected myocarditis or pericarditis? The answer is 0. A big fat 0. I mean, what a stark contrast to the all-in attack we just talked about. The guidelines are crystal clear. You hold off. But wait and support does not mean doing nothing. Not at all. It's a very active strategy. Supportive care means things like rest, anti-inflammatory drugs like steroids, and in really severe cases, a whole list of medicines to help the heart do its job. It can even mean doing a procedure to drain dangerous fluid from around the heart. It's all about being watchful and responsive. All right, on to our third and final scenario, which, you guessed it, needs a completely different strategy. This is rheumatic fever. And here, we're not using a massive assault, and we're not just supporting the body and waiting. The approach here is all about precision. Think of it like a sniper targeting one very specific enemy. For rheumatic fever, the game plan is this super clear 3-step process. First, you take out the bad guy, in this case, group A strep bacteria, with a specific antibiotic like penicillin. Step 2, and this is so important, you start a long-term plan to make sure it never comes back. And then step 3, you use supportive care to handle the inflammation. It's targeted, it's smart, and it's long-term. So let's pull all this together. We've looked at 3 different conditions that can show up looking awfully similar, but they demand radically different game plans. What it all comes down to is a really incredible medical balancing act. This is really the core message of this whole explainer. 3 conditions, 3 completely distinct philosophies. For infective endocarditis, you attack hard and you attack fast. For myocarditis and pericarditis, you support the body and you monitor everything. And for rheumatic fever, your strategy is to target the enemy with absolute precision. Which kind of leaves us with one final big thought to chew on. In a world where we have this incredible arsenal of powerful medicines, maybe the truest sign of wisdom, the absolute hardest choice a doctor has to make, is knowing when the best move is to not use them at all.